So basically, a patient has been diagnosed with a Gleason 6 prostate cancer. Only reason the patient will have Gleason 7 prostate cancer are two. We didn't pick up the 7 which was there at the first time, what we call tip of the iceberg phenomena, and it happens in my own biopsies, so it can happen to any biopsy. It has been happening less often with an MRI guided targeted fusion biopsies. It is happening less, but that's a possibility. That's one thing. Second thing is that over time it grew from an 6 to 7, and that is where the follow-up sequential monitoring becomes important. So how do we monitor these patients? So first time we did, so what is my protocol for doing an active surveillance? Patient comes with a Gleason 6 prostate cancer. First thing I do is to get it reread by my pathologist. Sometimes pathologists, 5% of the times, they change their mind. One's 6 is someone's 7, it happens. It's a perception discussion, so we check it out. I get an MRI scan if it has not already been done. And if MRI shows more impressive disease than the biopsy shows, then I think there is some disconnect, and I try to do an MRI guided fusion biopsy as a confirmatory. And third thing which I do is to do a special kind of an ultrasound scan, which is known as a micro-ultrasound. And I will ask question about micro-ultrasound to Dr. Vinayak in a second, so get ready for that. But I also like genomic testing. So Gleason scoring is a look of the cancer. Genomic is what's happening in the actual gene of that cancer. Sometimes good-looking cancers may have a bad-looking gene, and they may push the cancer to be more aggressive. And there are 3 different kinds of gene tests we can do. One is known as Polaris, other is known as OncoDX, and third is known as Decipher. I don't think there is much of a difference between 3. There are different kinds of gene sets which we look at it. So we do one of those tests, and 80% of the times there is a concordance with what I think the Gleason is and what genomic comes out, but sometimes there is a disconnect. I don't usually change the course of the treatment just based the gene as shown it, but families do get nervous, and I get a little bit too cautiously following in that. But we can talk about those discussions. So between Vinayak and Casey, what do you think is the importance of an exact view scan, which is a 29 megahertz micro-ultrasound, which looks something like this? So look at the resolution of this picture. The normal ultrasounds are 5 megahertz, 7 megahertz. This is in high resolution 29 megahertz picture, which gives a little, they call it microscopy level, but it is in higher resolution than the conventional ultrasound. So we do that, but the beauty of it is it can be repeated and it can be done by the doctor's hand, so we can focus on the area which we are concerned. So Vinayak and Casey are leading that program here, so please.
Yes. Thank you, Dr. Tewari. So this is called micro-ultrasound. Dr. Tewari already summarized. Conventional ultrasound that we used to do it 5-6 years before. It has a resolution of around 4 to 6 megahertz. Resolution is the picture quality, how good, how details you can see the prostate. So that has been increased to 4 to 6 times now, 29 megahertz. You can see very much details. You can see some dark areas looking like a cancer, bright areas looking like calcifications. There are certain things that we can look very carefully, and the major advantage of this micro-ultrasound is real-time imaging. So the urologist will be able to do it. He will be able to talk with the patient at the same time in the clinic, and he'll be able to tell, you have this lesion at this point, it is how much close to the prostate capsule, and it is either going out of the capsule, it is pushing the capsule, or something is happening to that area. So not only detection of cancer, but how aggressive the cancer is growing. Dr. Tewari said we can monitor it. You can do the ultrasound every 3 months or 6 months, so that if an area, abnormal area that was there 5 millimeters, 6 millimeters, after 3 months, if that 5 millimeters go to 7 millimeter or 8 millimeters, it means that something is happening in that area. So it's good to have a proper discussion with the urologist, and real-time imaging is one, I would say.
It also becomes very important in patients who have a pacemaker, patients who have some kind of metallic thing, and the patients who don't like getting into the MRI board. I do both, but in those patients, they definitely need to have something of this kind. It helps us in identifying the area which is of concern. But there's another area, and I'm jumping my steps here. Some of these patients need to go to the operating room, and you can see that the black line in the bottom is the capsule of the prostate, and just outside the capsule are the nerves. So, can this ultrasound pick up possibility of breach in the capsule? And that's where Casey's role comes, because Casey does them in a pre-op, and she is also assisting me in an operating room for the last 10 years. So Casey, what is your experience within micro-ultrasound and for that indication?
I think what's great about the micro-ultrasound is that in real time, I'm able to see if the lesion is, like Dr. Genomic expressed, is breaching through the capsule. And if it is, I can measure the millimeters. So at the time of surgery, Dr. Tewari knows in that area, he has to cut a little bit wider. In that area, the nerves are infected with the prostate cancer, and they're no longer the patient's friend. It's a great planning tool.
So, active surveillance patients are getting sequential what? Documented what is our protocol and how should we manage it?
So the protocol that we are trying to implement is that if you are being followed, and usually you have a Gleason 6 cancer, we want to make sure that it doesn't become a Gleason 6. You'll be seen, we'd like you to be seen 4 times a year. Once a year you'll be seen by Dr. Tewari himself and his team. Once a year I'll be seeing him as a surrogate for Dr. Tewari. And twice will be seen by the nurse practitioners or the PAs. Marla Gabriel is the PA who's who has expressed desire in controlling this. Once a year you'll get an MRI. Once a year you'll get the ultrasound. 4 times a year you will get a PSA. Once a year you'll get a rectal exam. You may get a new test called a PSMA PET-CT depending on what the MR shows. So we feel fairly confident that, in fact, we feel completely confident that we'll be able to pick things up with a 3-month delay at most. And that's between one visit and the next visit with this kind of follow-up.
So I have at this point, based on the last analysis, close to 12,000 patients who I have not operated on. So I have operated on close to 10,000 patients, but about another 12,000 I am following in one form or another. And as you can see, I have a vision for how to follow these patients up. So genomic is an important part. I don't like doing too many biopsies, so normally I do what I call a no matter what biopsy 3rd year after they have been put on an active surveillance. But I will do a reactionary biopsy if a patient shows a progression, and the progression or the trigger is patient's PSA goes up too high. But not only one thing. If PSA goes up, it could be infection, it could be something else also. If patient's MRI is showing something concerning. These are the 2 reasons when we worry about it, and that's when we escalate it to an earlier biopsy and all those things. We do 2 kind of imaging, MRIs and ultrasounds. I'm slowly incorporating with the due blessings from the insurance companies about the PSMA discussion. My hypothesis is that if a tumor is not visible on a PSMA PET scan in the prostate, it's unlikely it is a bad kind. So, but it's not in the standard of care, and some of the things we talk about it, don't go and talk to the other doctor, they may not be able to do it because that's still not the standard of care, but that's where the field is evolving, and I'm sharing some of the ideas which we are doing it.